Good evening, everyone. I'm Josh Rosenthal, Chair for the Council, a new organization dedicated to preventing opioid dependence and addiction in Rhode Island and the surrounding region. I know firsthand how important it is to educate stakeholders and the public at large. I lost a son, Nathan, at the age of 34 to a fentanyl overdose. I'm dedicated in his memory and in his honor to making sure that other families don't have to go through the pain that my family has gone through and continues to go through. We are pleased for our first webinar to have one of the foremost experts in the nation on the opioid epidemic, Dr. Andrew Kolodny. Dr. Kolodny is the medical director of opioid policy research at the Heller School for Social Policy and Management at Brandeis University and co-founder of Physicians for Responsible Opioid Prescribing. I am so very pleased to have Dr. Kolodny here this evening. I'll turn the webinar over to you, Dr. Kolodny.
Thank you very much. It's a pleasure to have this opportunity to give everybody an update on the opioid crisis. I am going to be talking about what's been happening currently, but I want to start with just a little bit of history. I'm starting with a very old slide. This is a slide that the CDC introduced in 2010. And you can see that the most current data that the CDC had on drug overdose deaths in 2010 was from 2007. So at that time, there was a 3-year lag in the data. We've gotten a little bit better there, still not great. We don't get the data as timely as we should. So there was a 3-year lag in the data. And when the CDC introduced this slide in 2010, it had just begun referring to the opioid crisis using the term epidemic. And when the CDC started to call the opioid crisis an epidemic, it began to get criticized. The criticism was mainly coming from individuals and organizations with financial ties to drug companies making opioids. And the critics said to the CDC, stop calling it an epidemic, you're exaggerating. And if you keep calling this an epidemic, you're going to scare doctors away from prescribing opioids. That will make the problem of untreated pain in America worse, so knock it off. The CDC responded by saying, we're the CDC, we don't use the term epidemic lightly. This is an epidemic. And then they went even further. They said, not only is this an epidemic, it's the worst drug epidemic in United States history. And that's the point that they're making with this graph. The box on the left is showing you that says heroin. That is showing you the rate of drug overdose deaths during the height of the heroin epidemic of the 1970s. And then if you look a little further to the right, the box that says cocaine, that's the crack cocaine epidemic that hit very hard in urban areas in the late 80s, early 90s. And what you can see is that deaths involving drugs continue to go up very rapidly after those two epidemics ended, which is why the CDC was calling this the worst epidemic. Now, the last blue column that you're looking at, that's 2007. Please keep in mind that in 2008, that blue column went higher. In 2009, it went up again. In 2010, it went up. Every year, it's continued to go up. And in recent years, it hasn't just jumped up a little bit, it's really skyrocketed, the number of overdose deaths. So what the CDC was referring to as the worst drug epidemic in United States history, way back in 2010, has only gotten much worse since 2010. Still, this is still historical data. This is showing us what the drug overdose, what drugs were involved in drug overdoses between 1999 and 2010. Of course, I'll show you what's happened since 2010 on the next slide. But up until 2010, what was driving the increase that the CDC was referring to more than anything else was this red line. The red line represents prescription opioids. Heroin, which is also an opioid, is shown in the bottom in green. And so what was really driving this problem more than anything else were prescription opioids. You see cocaine in blue had come up and then come down a bit. In recent years, you'll see it's come up again. There's a concerning trend involving benzodiazepines, which has continued to be very concerning. And then again, heroin is at the bottom. Now, this is 2010. What's happened since is on this graph. And here, orange is representing prescription opioids. And you can see that after 2010, the prescription opioid deaths stopped going up so rapidly. Do you see the yellow line at the bottom that starts going up around 2012? That's heroin. And then you can see around 2015, this very sharp rising blue line. That's representing illicitly synthesized fentanyl. Before 2014, that light blue line that represents fentanyl was likely to be prescription fentanyl, fentanyl in patches or in immediate release formulations. But after 2014, overwhelmingly, this increase involving fentanyl has been from illicitly synthesized fentanyl that's coming into the United States. Now, many people are looking at this trend or these trends in overdose deaths involving different drugs. And you can also see that deaths involving methamphetamine, which is the gray line, has also increased significantly in recent years. And you see cocaine has come up quite a bit in recent years. That increase in cocaine is mainly, these are not mutually exclusive categories. So what really drove the cocaine increase were deaths involving both fentanyl and cocaine. With methamphetamine, there has been a very real increase in just methamphetamine deaths. Now, some people are looking at these trends and drawing the wrong conclusions. There's sort of a popular narrative to explain these trends that's not really very precise and in many ways can be misleading. The popular explanation for what you're looking at is that around 2014, 2015, 2016, when you start to see deaths involving heroin and fentanyl, illicit opioids going up rapidly, the explanation for that is that there was a crackdown on the pills, or the CDC guideline got doctors to prescribe more cautiously, and that forced drug abusers, now I don't like the term drug abuser, but that's the narrative, the drug abusers or the addicts, which is another term which I'll explain later, I don't think we should try not to use. It's for different reasons. But the narrative is that the drug abusers and the addicts, they switched to the illicit supply because of a crackdown on the pills. That is not really what's been going on. It is certainly true that the vast majority of individuals who started using heroin or illicit fentanyl after 1996, it is true that for the vast majority, their addiction did begin with pills and they switched, but the switching doesn't happen in 2015. The switching starts to happen much earlier, at the beginning of the opioid crisis. People who were getting addicted to prescription opioids were switching, and I'll explain that a little more in a moment. This is the most current data available from the CDC, available since May 1st. This is what they've released. And right now there's about still quite a bit of a lag in the data. The most current data we've got is ending, it's about a 6-month lag. So the last dots, or the end of the lines that you're seeing at the very right, that's ending December 2021, and it's showing you the number of deaths, which is what you see on the y-axis to the left, the number of deaths that occurred during a 12-month period ending where that dot is. And so what you can see here is that for the most current data we have, which is the year ending 2021, The brown line at the top is really what has been involved in most of the deaths. That's illicitly synthesized fentanyl. That was involved in about 70,000 deaths. Coming down, you'll see the gray line, which is methamphetamine. Then the purple line, which is cocaine. Coming further down, you'll see prescription opioids, then heroin, and then you see methadone at the bottom. And the methadone represents both prescription methadone for pain as well as methadone prescribed for addiction. So that could probably be added to the green column. And what you can also see is that if you look at around January 2020, which is around when COVID began, you see that that brown line really started to go up even more rapidly. We had experienced a soaring increase in deaths involving fentanyl prior to COVID, but what you can see clearly is that after January 2020, those fentanyl-related deaths increased even more rapidly, and I'll talk a little bit more about that as well. This is the same graph, just zeroing in. It's just a close-up of what's been going on since COVID. And you see, again, the very sharp increase in fentanyl deaths. You see almost a decline in a small decline in heroin. Prescription opioids have remained pretty constant. And of course, increases in methamphetamine and cocaine. This is also some very current data, also very disturbing data. What we're looking at is a very sharp increase in overdose deaths in adolescents. And what you can see is, so for adolescents, in general, when you look at the age groups of people dying of opioid overdoses, historically, there have been very few, comparatively, deaths in adolescents. Up until around 2019, there were about 500 teenagers every year dying of a drug overdose in the United States. And the deaths were mostly in young adults and older and middle-aged adults and older adults was where we were seeing most of the deaths. Something that's happened very recently, you could see that beginning around 2019, which is the graph on the left, you see very sharp increase in deaths in adolescents involving fentanyl. And when you look at the right, you'll see a little bit of the epidemiology, the way that the problem is affecting different populations. You'll see very concerning the different groups that were involved. The increase in fentanyl-related deaths has been greatest in American Indians and Alaska Native teenagers. But we've seen the increase in basically every teenage group. Now, still, compared to the total number of deaths in teenagers are much fewer. So we went from about 500 a year to about 1,000, a doubling. But keep in mind that in the year ending December 2021, we lost about 100,000 Americans to drug overdose deaths. So the vast majority of the deaths are occurring not in teenagers, but in young adults, middle-aged adults, and older adults. And the vast majority of the deaths are occurring in people who are addicted. For these teenagers, this is more likely to be recreational use, experimental use, resulting in loss of life. But for most drug overdose deaths, most occur in people suffering from addiction. Now, I mentioned earlier that there's this narrative that the switching from the pills to the illicit supply happens around 2014, 2015 in response to a so-called crackdown on pills. I'm showing you this slide to make the point that the switching began much earlier. And I'm going to explain this graph. On the right, you're looking at African Americans. On the left, you're looking at whites. The color of the lines are referring to age groupings. If you look at the red line on the right, which would be African Americans ages 20 to 34 years old, you see no real increase in heroin. And what you also may notice if you look closely is that among African Americans, the age group with the most heroin would be the 45 and up group. Now, and those are generally survivors from the heroin epidemic of the 1970s and 80s. If you look to the left, you'll see this soaring increase in heroin among young white people in the United States in this 20 to 34 year age group. And these are young people who developed their opioid addiction from prescription opioids. They became addicted to prescription opioids that they were taking recreationally, or maybe they became addicted to prescription opioids that were prescribed to them. Another term for that would be iatrogenic addiction, a young person prescribed opioids aggressively who becomes addicted to them, or they became addicted, sort of a combination, maybe a brief medical exposure, wisdom teeth, sports injury. They don't become addicted from that brief medical exposure, but they basically get their first taste of the drug from a doc or a dentist, and then there's a period of recreational use that follows, and then they become hooked. Regardless of how these young people became addicted, once they became addicted, and once anybody becomes addicted to opioids, you're not using because it's fun anymore. Once you're addicted, once you're physiologically dependent on the drug, without it, you feel very, very sick, and that's what drives continued use. So these young people who become addicted, they have to maintain their supply. And even young people who might have become addicted to a doctor's prescription, doctors, even back in the early 2000s, were not that comfortable giving young people a very large quantity of opioid pills on a monthly basis. I think we've been too comfortable, and still are, prescribing opioids aggressively for acute pain in young people. But for chronic pain, doctors didn't want to give, and still don't like giving, healthy looking 25-year-olds a large quantity on a monthly basis. And so the young people who were becoming addicted to the pills wound up on the black market. The pills, even from the beginning of the opioid crisis, were very expensive on the black market. So if that young person was in a region of the country where heroin was available, they'd switch. Heroin, we've seen flood into more regions of the country where it wasn't previously available, to meet the demand for it by this growing number of young people who develop their addiction from prescription opioids. Now, I want you to look at the green line on the left, white people 45 and up. You don't really see much rising use of heroin, and this ends around 2013, but we still haven't really seen much rising use of heroin. Now, this does not mean that middle-aged and older white Americans have been spared from the opioid crisis. They haven't. It's a group that's been hit just disproportionately hard. But this is a group that really hasn't been switching to heroin. It's a group that has been able to get pills much more easily from doctors. It's a group that's really developed its opioid addiction through medical use, and again, hasn't had to wind up on the black market. Prescribing has started to trend in a more cautious direction, and there's certainly a risk of older people who are addicted to pills switching to an illicit supply. But where we've really seen the rising use of heroin and the fentanyl deaths, which I'll show you, are in this younger white group and an older black group. Up until 2012, before fentanyl emerged, when you looked at where we were seeing most of the deaths, most of the deaths were in this 45 to 54 year age group, and they involved this OPR, opioid pain reliever, the light gray. If you look at the dark blue, that's heroin, and for heroin, even back in this time frame, for heroin, you saw more of the deaths in that younger group, the 25 to 34 age group. In recent years, as the illicit supply became much more dangerous with the emergence of fentanyl, you started to see deaths in that younger group catch up. Now, fentanyl initially had a quite striking geographic distribution. When fentanyl emerged and it caused the death toll to start going up so rapidly, the distribution, it was really mainly limited to the eastern half of the United States. The western half of the United States really didn't have that much fentanyl. This, of course, has changed after COVID. We started to see fentanyl deaths occurring and increasing rapidly throughout the United States. It was no longer just limited to the eastern half of the United States, which is one of the main reasons we've seen deaths go up so rapidly during COVID. If you look at the geographic area that experienced the greatest increase in fentanyl-related deaths, what might surprise many people is it was the District of Columbia, it was inner city DC, where the fentanyl deaths went up the most. And the reason for that, and the reason we saw fentanyl deaths rise very rapidly in inner city communities that had been hit very hard with heroin in the 1970s is because there is this aging population of survivors from that previous epidemic. Roughly speaking, and this is really important, this slide is really important to understand if you're going to make sense of the opioid mortality trends that I showed you in that initial slide. This is the epidemiology of opioid addiction in the United States. In other words, this is the way opioid addiction or opioid use disorder is affecting different populations differently. We have the first group, which is younger, and this says 20 to 40, but right now they're really more in their mid-20s to mid-40s because the group is aging a bit. These are individuals who became addicted taking prescription opioids, medically or recreationally, and they've switched to heroin, and that switching began a while back. And then you have this middle-aged and older group, people in their 40s up through their 80s, who haven't really been switching to heroin. This is a group that develops addiction also from prescription opioids and has mostly been losing its life to prescription opioids. Lastly, you have this older non-white group, African American and Latino, which has where we've seen a very significant increase in deaths in recent years. These are individuals who became opioid addicted mostly in the 1970s. Some became opioid addicted during the crack cocaine epidemic. There was also a lot of heroin use associated with the crack cocaine epidemic. This is an aging, shrinking cohort of people who are really longtime survivors of a previous epidemic. These are roughly the three groups of opioid addicted Americans. The one group not captured on this slide, which is very significant, would be Native American, American Indians and Native Alaskans. So when you look at where the fentanyl has taken its toll, you'll see it's this light blue line at the top, which represents white men 30 to 40 years old, and the purple line, which is black men 50 to 60 years old. You also will see this, if you look at 2006, where you see this peak in deaths in black men, 50 to 60, that was when the United States experienced a fentanyl outbreak related to fentanyl that was ultimately traced back to some Mexican cartels. And the cartels, I think the DEA was able to intervene, that the fentanyl stopped coming in, and we didn't wind up with another serious fentanyl problem until around 2014, when you start to see fentanyl coming back into the United States, being mixed in initially mixed into heroin, increasingly just replacing heroin. It's fentanyl and cut. The practice of mixing fentanyl into heroin is believed to have begun with the fentanyl patch. There were drug dealers who were extracting fentanyl from fentanyl patches, mixing it into their heroin to boost up the potency to make their heroin more competitive. And ultimately, the cartels began to manufacture the fentanyl themselves. So that's believed to be one of the ways in which the mixing of fentanyl became so common. This is showing you drug overdose deaths in individuals 55 and older. And here, when you zero in on this older group, that's where you see this blue line on the right. Unfortunately, this graph has lots of blue lines and it's hard to decipher them. But that dark blue line where you see this very sharp increase, that's showing you deaths, and it's primarily the fentanyl deaths that are occurring in African Americans and non-Hispanic Blacks. who are 55 and older. Again, survivors from an earlier epidemic. That was death data. This is treatment admissions data. It's showing you, it's trying to measure who's addicted by looking at who's getting treatment. And here, if you start on the left, you're looking at whites, males on top, women on the bottom. And if you look at white people who are getting treated for addiction involving heroin, you'll see that it's, again, the peak age is this young adult grouping. And you see over time a little bit of a shift to the right, and you see this increase. And it's similar for women. For blacks, and you may not notice this unless you look very closely, the scale is a little bit different. But for black men, it's much more than black women. Again, you'll see that the peak ages are much older, and you again will see over time a shift to the right, meaning this addicted group is aging, and it's a cohort that became addicted. These are headlines that I pulled off the internet that have appeared in newspapers over the past several years to describe the opioid crisis. Really important concept, I think, is, or a really important way to understand the opioid crisis, the correct way to frame the opioid crisis is important if you're going to think about strategies to bring the problem under control. One of the reasons I believe that the opioid crisis has gotten worse for so many years now is because all of these different health and social problems that we refer to as the opioid crisis were misframed, and to some extent intentionally misframed by Purdue Pharma and the Sackler family and the opioid industry in general, which didn't want to, which wanted policymakers to think that all of these problems were driven not by addiction, but by abuse. That the opioid crisis was a problem of people taking dangerous drugs because it's so much fun and they're accidentally killing themselves. And when you frame it that way, the challenge then is, well, how do we stop people from behaving badly? And another way that the opioid crisis has been misframed is by focusing too much on the deaths, and to think of the crisis as an epidemic of overdose deaths. The problem with doing that is that it misses the fact that the vast majority of the deaths are occurring in people who are addicted. We've certainly seen a sharp increase in teenagers who are not addicted because the illicit supply is so dangerous in a teenage recreational user, which is a very serious problem for which we need interventions. But that's about 1,000 deaths. We had 100,000 deaths in 2021, and the vast majority of those deaths occurred in people who are opioid addicted. Focusing exclusively on the deaths would be like framing the AIDS crisis as an epidemic of PCP pneumonia, which is what many people with AIDS were dying from. The AIDS crisis wasn't an epidemic of PCP pneumonia, it was an epidemic of HIV infection. It was an epidemic of a condition that was preventable and ultimately treatable. That's really important to recognize. If we frame the opioid crisis as an epidemic of opioid addiction, what we're saying is that all of these different health and social problems, the soaring increase in overdose deaths, the flood of heroin and fentanyl, rising rates of infants born opioid dependent, outbreaks of injection-related infectious diseases, impact on the workforce, children winding up in foster care. What we're saying is that the driver behind all of these health and social problems that we refer to as the opioid crisis, what's driven this has been the sharp increase in the number of Americans suffering from a preventable, treatable condition, opioid addiction or opioid use disorder. I'm going to show you the epidemic happening over time. So this is 1999. It's 3 years into the epidemic. I believe the opioid addiction epidemic began in the year 1996. So this is 3 years into the epidemic. And the states that show up as red or maroon are the states with the highest rate of people addicted to prescription opioids seeking treatment, showing up at state licensed drug and alcohol treatment programs. So the states with the highest rate of people addicted to prescription opioids show up as red or maroon. I want you to watch what happens as we go forward in time. You could see in 1999, you have a few states showing up as red or maroon with the most serious problem. In 2001, you see more states turn red. 2003, 2005, 2007, and 2009. By 2009, every state in the country had experienced this very sharp increase in the number of Americans suffering from the condition of opioid addiction. And when you have a sharp increase in a disease over a short period of time, that really is the definition of an epidemic. Now, what caused the maps to turn red? What caused our epidemic of opioid addiction and overdose deaths? The first and best answer to that question came from the CDC. It came from a medical director there, Dr. Len Palazzi, who passed away recently. Len worked at the CDC's Injury Prevention Center, and he was responsible for accidental deaths in the United States. And in the early 2000s, he starts to recognize that deaths in the United States from poisoning are increasing rapidly. And he looks at this trend and he says, if this trend continues, there'll be more Americans dying from poisoning than dying from car crashes, which had forever had been the number one cause of accidental death in the United States was a motor vehicle accident. For decades had been motor vehicle accidents. Suddenly poisonings are beginning to surpass motor vehicle accidents. And a few years later, as Len predicted, it did pass motor vehicle accidents. So today, the most common cause of accidental death in the US is not a car crash, it's an opioid overdose. So Len is seeing this trend and he has to make sense of it. This is his job. And to really answer the question of what was causing the rise in the deaths, he did something pretty neat on this graph. He charted out in orange deaths involving prescription opioids. And then in yellow, he charted out the sales for prescription opioids. And what he was showing us with this graph was that what really drove the increase was this very sharp rise in the prescribing of opioids. That as the prescribing went up, the deaths went up directly in parallel with the rise in the prescribing. The CDC put out this graph a few years later, and it's making the same point. Here, the green line represents sales for opioids or opioid consumption, prescription opioid consumption. The red line represents deaths involving prescription opioids, and the blue line represents addiction measured by treatment seeking involving prescription opioids. The CDC's point was that the rise in the green line had caused the red line and the blue line to go up. And their message to the medical community was that that green line needs to come down if we want to bring the opioid crisis under control. I could tell you that drug companies that have manufactured opioids and sold them and were promoting aggressive prescribing have not agreed with the CDC. And as these lines started going up together, scientists, drug companies were paying scientists to publish papers saying that what we're looking at was actually not happening. Papers saying that the prescribing has gone up, but there's no evidence of any adverse public health consequence. By 2005, 2006, they stopped making that argument when it became so obvious that there were public health consequences. That's when they started to argue that if we make the pills hard to crush, so-called abuse deterrent formulations, then we can have our cake and eat it too. The green line can keep going up and we'll be able to make the red line and blue line go down. Drug companies were not just saying these things, they were putting their money where their mouth was. So as the prescribing is going up, as policymakers are starting to recognize that this isn't an epidemic of people taking pills because it's fun or kids getting into grandma's medicine chest, as policymakers start to recognize what's been driving the problem all along is this surge in opioid prescriptions, that we've flooded the country, that we've overexposed the population to this highly addictive class of drug. As policymakers start to figure this out and consider maybe we want to take steps that might help bring that green line that we looked at down, the industry spent quite a bit of money trying to block any kind of interventions that would have resulted in more cautious prescribing. So the companies and the front groups they were working with spent $880 million over a 10-year period blocking efforts that might have resulted in more cautious prescribing. Spent 8 times more than the gun lobby was spending trying to block gun control laws, spent 200 times more than groups that were calling for more cautious use of opioids. I mentioned that the epidemic began in the year 1996. This slide can help you understand why I said that. This slide is showing you oxycodone consumption in the United States compared to Europe. And the blue line is the US, the red line is Europe. And you can see it not even close. You can also see that 1996 is the year that the oxycodone consumption really explodes. And you may know that 1996 was the first year that OxyContin was on the market. So you could look at this and say, well, prior to 1996, we're looking at just Percocet. After 1996, you're looking at OxyContin, which is being widely prescribed and marketed. It's also the Perc 30s, the roxycodones, the Mallinckrodt M30s, the pure oxycodone, and there's just this massive increase. And you'd be correct if you said that, but keep in mind that in 1996, it wasn't just oxycodone that starts to go up rapidly. All opioids begin going up rapidly. Every class of opioid that was on the market, 1996 is an inflection point where the prescribing starts to take off. And the reason is that when Purdue Pharma introduced OxyContin, it certainly did a lot of deceptive branded marketing of OxyContin, but it also tried to change the culture of opioid prescribing in the United States. And other drug companies with opioids very quickly joined in with this effort to change the culture of opioid prescribing in the United States by working with front groups and professional societies. The Joint Commission adopted the Pain is the Fifth Vital Sign campaign, and even state medical boards across the country were influenced by their trade association, which was taking money from Purdue and other opioid manufacturers, so that state medical boards began encouraging doctors to prescribe opioids aggressively. All of this really led to a change in the culture of prescribing and led lots of Americans to become opioid addicted. There has recently been quite a bit of litigation against the opioid industry, not just Purdue, which was very clever. The Sackler family was very clever. After they settled with the state of Oklahoma for a couple $100 million, they then put Purdue Pharma into bankruptcy. And so they've been out of the opioid litigation. They've been in the bankruptcy court, where there's still no, there's this pending bankruptcy deal, which has been criticized because the Sacklers will get to walk away billionaires, and because the plan involves states taking, basically Purdue Pharma doesn't get liquidated, which is what should happen when companies go into bankruptcy. And certainly if it's a company where the employees were doing not such good things, they should potentially lose their jobs. Instead, Purdue will be turned into a public benefit company. People working at Purdue keep their jobs, and the profits from future sales of OxyContin and other Purdue products then go to the states, which creates an incentive for states to benefit from aggressive prescribing, which is a perverse incentive. States should be promoting more cautious use. But it wasn't just Purdue. Other drug companies did what Purdue was doing. And it wasn't just drug companies, as in opioid manufacturers. Distributors were very involved in failing to follow the law as DEA registrants, and supplied pharmacies where millions of pills were going out the back door. And even many pharmacies played a role in the opioid crisis. So just a couple of weeks ago, Walgreens settled with the state of Florida for $683 million for its failures and for its role in the opioid crisis. So lots of companies have been sued, and many of them are now beginning to settle. This, of course, is a very good thing potentially, because it could mean literally billions of dollars for from the companies that really played an important role in causing this crisis, money that can be used for bringing the problem under control. So this is showing you again another comparison in prescribing. You do see the United States is not surprisingly at the very top here with the blue line, and you're looking at the United States compared to the other countries in the world with the most opioid prescribing. There are some countries with very little opioid prescribing, even countries with good healthcare systems and aging populations like Japan, which has extremely low per capita opioid use. But these are the countries with the most per capita opioid use. And you could see the United States, we are starting to trend in the right direction, but we are still prescribing far more than other countries. And you'll see that even back in 1992, we were prescribing more opioids per capita than any other country. So sometimes you'll hear people talk about the swinging pendulum, that the medical community was under prescribing in the 90s, and then we overshot the mark, and now we're under prescribing again. That pendulum narrative is false. We have been prescribing more opioids than other countries for a very long time, and even though prescribing is trending in the right direction, we still prescribe far more opioids per capita than any other country. You'll see this in more current data. The prescribing continues to trend in the right direction. There are some reasons to believe that the trend has slowed down a bit during COVID, where some of the rules were loosened on opioid prescribing for pain, just as some of the rules were loosened on treatment of opioid addiction. So it's unclear if we're still trending in the right direction. But you could see we have a long way to go before we get back to rational levels of prescribing. As you all know, prescribing has trended down, deaths have gone up. And there are many who are arguing that it's the decrease in the prescribing that caused the deaths to go up. I hope you'll agree that what caused the very sharp rise in deaths was a much more dangerous illicit supply, not a sudden switching from prescription opioids to the black market. In fact, the switching to the black market was really happening as prescribing was going up. And even if you look at the peak of this graph, which goes from around 2009 to around 2013, that's when the heroin line was started to go up pretty rapidly. We saw heroin deaths rising when we were at the peak levels of opioid prescribing in the United States. The oversupply was driving heroin use, not the decrease. So we haven't seen the same decline in deaths that we would like to have seen because of the more dangerous illicit supply. We haven't seen deaths coming down with the decrease in prescribing. But this is somewhat promising. This slide is both extremely disturbing, but it also shows us some light at the end of the tunnel. This is Florida. I could tell you the trend looks very similar for most states. What you see is a sharp rise in infants born opioid dependent that lags the increase in the prescribing by a few years. And then you see a decrease in infants born opioid dependent happening a few years after the prescribing starts to trend in a more cautious direction. What we're really looking at here, what's so disturbing about this is this represents nationally tens of thousands, maybe hundreds of thousands of infants born with opioid withdrawal, which is an excruciating experience for the infant. It's unclear to what extent the infants who are exposed in utero to opioids may have some lasting effects on their development. Of course, the moms are often racked with guilt to see their infants experiencing opioid withdrawal, because these moms know what their infants are going through, because they themselves have often experienced opioid withdrawal and know personally how excruciating it is. So, I mean, this represents a real tragedy. At the same time, the decrease gives us some reason to be hopeful. What I think we're really measuring with neonatal opioid withdrawal or neonatal abstinence syndrome, what we're really measuring is opioid use disorder in women of childbearing age, or opioid use in women of chronic opioid use in women of childbearing age. And this suggests that fewer women of childbearing age are becoming opioid dependent. It means that there's potentially some light at the end of the tunnel. How do we bring the opioid crisis to an end? We have to prevent more Americans from becoming opioid addicted. We have to see that those who are addicted have access to effective treatment. There is an important role for harm reduction, and there is an important role for law enforcement. We do want to try and keep fentanyl from coming into the United States. We do want interdiction efforts to make the black market supply, not just opioids, but even methamphetamine, more expensive. What we know from historic trends, when the price is low and the purity or the potency is high, more people who are addicted and using the drug die. If you can make the price higher and at the same time have a massive expansion in access to treatment, then more people will seek treatment. The Biden administration is going full throttle on harm reduction. I think that's a good thing. I think there is certainly a role for making naloxone more available. There is a role for safe injection facilities in urban areas where you have large numbers of homeless injection drug users, and where you're also expanding access to treatment. They can be a place where you can get people into treatment. I don't know that safe injection facilities make much sense in suburban or rural communities, because I don't think people are going to commute into town multiple times a day to inject. But in urban areas, they're also an intervention worth piloting and studying. This is a graph I'm showing you. I want to make a couple of final points. This is the AIDS crisis. And you could see the AIDS epidemic began in 1980, and we had a peak number of deaths around 1994, 95, and then deaths plummeted. And why did we see deaths from AIDS plummet? It's because we had the introduction of antiretroviral therapy. We were able to treat HIV, and we made a decision as a country that anybody who was HIV positive should have access to antiretroviral therapy regardless of their ability to pay for it. We created new funding streams, Ryan White funding, to make that possible, and we saw deaths plummet. We basically turned HIV from a terminal disease into a chronic disease. I really do think we could potentially achieve this with our opioid crisis. We are still we're still going up rapidly, but if we could massively expand access to effective treatment, and I'm mostly talking about treatment with buprenorphine, I think we could see deaths plummet. I'm not just speculating. This is a graph from France where buprenorphine was released without the same restrictions we have in the United States. And the gray line is the increase in buprenorphine prescriptions. The black line going down is showing you the plummeting in heroin deaths. I don't think we could pull this off because our epidemic is so much more severe. France was dealing with a cohort of older heroin users. We've got a massive percentage of our population addicted to opioids, but I really do think we could get deaths to come down. Shatterproof did some nice work demonstrating how we have very inadequate access to buprenorphine in the United States. About 6% of doctors in the United States, only about 6% are even eligible to prescribe buprenorphine. We have many counties throughout the United States where you don't have an adequate number of doctors who are able to prescribe opioids. Just a couple of points about COVID. As I've touched on, COVID did make the opioid crisis worse. And it also slowed down the litigation, which meant, putting so the states that so desperately could benefit from that opioid litigation money, it had halted the litigation. That's picked up again, fortunately. Opioid use disorder increases the risks of COVID and the severity of COVID. Chronic opioid use, and that's true whether you're a pain patient on opioids around the clock, whether you're a heroin user, it's true even if you're on methadone maintenance, and possibly true if you're on buprenorphine. Chronic use of opioids suppresses your immune system. So it can increase the risk of getting COVID and getting a more severe case of COVID. We have some research that has shown us that that opioid use disorder, particularly in Black patients, was a significant increase the risk of death from COVID. There were some treatment system changes involving methadone and making buprenorphine more available, but I don't think those system changes were able to offset the difficulty people might have had in accessing treatment. And of course, the social isolation may have caused many people who were in remission with their opioid use disorder to relapse. There's also a concern that long COVID is resulting in an increase in opioid use. Long COVID or chronic pain is not a good reason for people to be using opioids. Opioids are awful drugs for chronic pain, because when you take them chronically, you get tolerant to the pain relieving effect, and then the patient gets stuck on the drug. It can be hard for them to ever come off. To keep getting pain relief, they often need higher and higher doses, which makes it more dangerous. It's very concerning to see increased use in people with long COVID symptoms. One point I think we could learn from COVID would be the benefits of surveillance. With COVID, we know on a county level, on a zip code level, the positivity rate. We have hospitalizations, we have deaths, and we get that data in real time. We are now 25 years into the opioid crisis. We have terrible surveillance. There's only one state in the country where we have a reasonable estimate for how many people even have opioid use disorder. And even the death data, as you can see, we've got a 6-month lag, and then it's still even marked provisional. So we need to do a much better job of improving surveillance. So I will stop here and take a couple of questions.
Thanks, Dr. Kolodny. That was incredibly informative. As you can imagine, we have a lot of questions and unfortunately a little bit of time to answer some of them. So I'll start with the first question that we saw a lot of people asking. How is the opioid epidemic affecting older Americans?
That's a good question. Older Americans have been affected in different ways. In some of the communities hit hardest by the opioid crisis, many older Americans are raising their grandchildren. Older Americans who might have been planning to retire, but because of their children's opioid addiction, they're left raising their grandchildren. It could be that they've lost their children to their adult children to opioid overdoses, or they are possibly incarcerated, or their addiction is too severe for them to raise their own children. So that's one way. But seniors have also been disproportionately impacted and are still disproportionately impacted by aggressive opioid prescribing. So many seniors have become opioid addicted. Many have lost their lives to opioid overdoses. They tend to go counted less often because their death gets attributable to the different medical problems rather than to an opioid overdose. And now that doctors are starting to prescribe in a more cautious direction, many seniors are having a harder time accessing opioids that they've become dependent on. It's very hard for people to come off of opioids. So just helping these many seniors who are stuck on opioids, even if they haven't clearly become addicted, is also quite challenging. Again, seniors are, as we get older, we have more pain problems, so it puts them at much greater risk of being exposed to opioids.
Thank you for that. I think one last question we're going to have time for is, what are your thoughts about the CDC draft guideline on opioid prescribing for chronic pain? We've just had a lot of people asking about chronic pain in the chat.
So yeah, as I mentioned, opioids are awful drugs for chronic pain. We do have millions of Americans who are stuck on opioids, some of whom are convinced that the opioids are actually helping them because before they take their first dose in the morning, they're feeling excruciating pain. They take a dose and now they can walk the dog and function. And so they believe that the opioid is treating their underlying pain problem, when in reality, the opioid is probably treating the pain hypersensitivity caused by the previous dose wearing off. If these people could really come off completely, which many can't, and we shouldn't force them off, many would, for those who have been able to come off, many will have a less pain, or at least the same pain, off of opioids, but with they feel more alert and no opioid side effects. But many will not be able to come off, and we have to help that population. The CDC issued a guideline in 2016, which called for more cautious prescribing, pointed out that we don't have evidence that this helps people, but we do have evidence that it's dangerous, and also issued some dosing guidance, asking the medical community to avoid going above 90 MME, and really recommending that for acute pain, you limit the prescription to 3 days is usually enough. Some states or some health insurance companies began to try and operationalize those guidelines. Some did this in intelligent ways. In some cases, there were reports that patients dependent on opioids were winding up getting cut off, which of course is terrible because going into acute withdrawal can be an excruciating, horrible experience. The CDC received quite a bit of pushback, much of it also exaggerated by front groups and by individuals with ties to drug companies that didn't want to see prescribing going down. So received quite a bit of pushback on that guideline. They recently issued a new guideline which included all of the new evidence on opioid use for chronic pain, which got worse for using opioids long term. In fact, instead of 90 MME a day, the new CDC draft guideline points out that 50 MME a day, which would be about 10 Vicodin a day, regular strength Vicodin, is a high dose that we should really avoid and is dangerous. So the new guideline has a lot of new, very helpful information in it. It summarizes the data very well. The only thing I'm not crazy about in the new draft guidance is the last page of the document are these bulleted recommendations. And because the CDC was afraid that policymakers might draft strict rules that could result in a problem, they pulled out the explicit recommendations from the bulleted portion, which I don't think was a good idea. I think there are other ways we need to address the problem of the legacy patients. But overall, the new guideline contains quite a bit of very helpful new evidence against using opioids aggressively. And relevant to the Council to Prevent Opioid Dependence, the new guideline points out very clearly that if you're on an opioid for more than even 3 days, you're going to start becoming dependent. And that doctors, even if they're going to prescribe 5 days worth, should really have a plan for getting the patient tapered so they don't experience withdrawal symptoms.
That's great information. And I think we have time for a very brief answer for a third question, and then we'll flip it over to Josh for some closing remarks. The last question is, has there been success in decreasing the number of opioid prescriptions by using alternative pain medications or procedures?
That is unclear. So there's a paper out recently by a group of interventional pain doctors, which is making the case that the interventional pain procedures have not increased, even though opioid prescribing has gone down. Interventional pain doctors are doctors who treat pain sometimes with injections and procedures. Many of them are anesthesiologists. Some interventional procedures actually don't have very good evidence to support their use either. And there are many interventional pain doctors who are getting lots of referrals of patients who are stuck on opioids. The primary care doc doesn't want to continue the opioid prescription because the primary care doc got the memo that these aren't good for chronic pain. They refer to the interventional pain specialists. Some of these, and so some of these patients are also getting opioids and interventional procedures that are not necessarily that helpful. In fact, some of the interventional pain doctors, for example, there's an interventional pain doctor who heads up the organization, who's one of the most largest opioid prescribers in his state. So they do a lot of prescribing. I don't know that they're necessarily a good option. We do have alternatives to opioids. They include non-opioid analgesics like NSAIDs, which have their own downsides, and not everybody can take an NSAID, but they are generally safer than opioids. They are sold over the counter for a reason, and even for severe pain, they can be very effective. And in hospital settings, injection use of NSAIDs can be as effective as morphine, even for severe pain like kidney stone pain. So that class of drug is very effective for severe pain. Tylenol can be combined with NSAIDs because they work differently. For many people with chronic pain, depending on the cause of their chronic pain, physical therapy can be very helpful. Other non-pharmacologic approaches, exercise, weight loss. It is very hard to answer the question, if not opioids, then what? Because it depends very much on the specifics of a patient. But we really don't have good data that the decrease in opioid prescribing is accompanying an increase in some of the other modalities. We've seen an increase in tramadol, which is a weak opioid, which is not necessarily a good sign.
There's a lot to consider here, and I want to thank you very much for your time today, Dr. Kolodny.
Thank you.
At this point, I would like to turn it back over to the chair, Josh Rosenthal, of the Council to Prevent Opioid Dependence. Josh.
Andrew, thank you so much for your thoughtful and learned. Certainly learned a lot from me, having lost a son to fentanyl, which is actually mixed with cocaine. So it wasn't entirely clear that he knew what he was getting into, and that he was a chronic pain kid with chronic pain. Thanks for all for participating. This is a new organization. If you'd like more information, we are tax deductible. You can visit ctpod.org. Thanks for taking the time. Thanks for raising the hard questions. Have a good evening. Back to you, Greg.
And thank you, everyone. We appreciate you joining us tonight, and check your emails tomorrow for follow-up information about obtaining a copy of this presentation and watching a recording. Once again, thank you very much and have a good evening.